So we're going to move to another topic. We spoke about basics previously. We talked about reduction of fracture and fixation of fracture arthroscopically. And we go to the second indication of arthroscopic in the French Arthroscopic Society, the second indication, which is the arthrolysis. So we're going to have some overview about that, about the indication and the techniques. Indication of arthrolysis concern, of course, the arthritis, which can be primary or secondary to a trauma, and it can be also in relation with some kind of synovectomy, which is the same procedure, arthroscopic procedure, in case of synovitis, inflammatory, septic, or hemophilic. The indication that, as I told you, osteoarthritis is probably the most frequent one. It could be primary or secondary. It's well tolerated for a long time. That's why often we see such arthritis with large defect of bone, with large loose bodies, with spurs and so on, which can be tolerated for a long time. So when you have such an elbow, you can sometimes consider arthroscopic treatment. The limits of the arthroscopic treatment for arthrolysis is, of course, every extra-articular factor, like in this case of malunion. When you have an evolutive stiffness, analgodystrophy, celiac syndrome, of course, you have to avoid any treatment about that. When the symptoms of stiffness is longer than 2 years, lasts since 2 years, for some people, 1 year is the limit. For some other, like as Schindler, it's not in relation. But in our study, we will see later on, 2 years seems to be a limit to propose with, for expectation of a good result, an arthroscopic treatment. And of course, in all major loss of bone stock. When you perform such a procedure, you have to make a preoperative planning, as I told you this morning. And in my experience, the CT scan, the arthro CT scan is mandatory to know exactly how it looks like your joint, outside and inside. And the bone scan is also mandatory to be sure there is no celiac syndrome. So this preoperative planning will show you the bony anatomy, the intra-articular regarding the fossa filling, the presence of or not of loose bodies, and the degree of capsular retraction or hernia in case of synovectomy. Of course, you have to pay attention to any previous surgery regarding the nerve or regarding the scars. And when you have such a procedure before, you must be very careful on the indication of arthroscopic treatment. You have to be sure where are located the nerves. And if the procedure before was extensive, you have to avoid an arthroscopic treatment because sometimes the nerve is stick to the capsule and it's at risk when you make the arthroscopic procedure. Just to explain you some cases, is there a 3 arthro CT scan with injection, arthro CT scan. Here is a normal CT scan. That means you have between the coronary fossae and the olecranon fossae a thin bone block with some synovium in the on each part. On the horizontal plane, that's what it looks like. After a dislocation, you see here there was a coronary fracture which has been removed. You have the same thin bone, but a filling, a fibrous filling of the fossae, which is much more important. So you can expect from a resection with a shaver, a simple resection with a shaver, an improvement of the mobility. And of course, when you have some long delay between the trauma and the operation, you can have a full filling of bone with spurs on the sagittal imaging and on the horizontal imaging. And of course, in this case, you have to resect a lot of bone, and you can do it arthroscopically. The operative procedure, I just remind you that you have to inflate the joint, and it's much more important in this case that in normal arthroscopy, you use the same 5 portals I described this morning, which are switchable. 3 steps. The first one is the scar tissue resection. The scar tissue resection, you have to make a room, because usually in this joint, there is a lot of fibrous tissue. You have to, and this room is made with in the area when it's not risky, and usually it's in the posterior fossa, just under the triceps. In this place, you can move largely with your instrument without any risk to clean the olecranon fossa. And step by step, you remove all the fibrous bond in the gutters, then anteriorly, progressively, paying attention to the cartilage. The second step is the bony excision. The bony excision is, of course, the loose body, which are very frequent in arthritis. It's a pulse resection. Here you have a radial head with a arthritis. You have a posterior bone spurs, which is quite important regarding the size of the burr, and you can resect it without any difficulty with a burr or with a curette or whatever you want. Then you can open the space between both fossae from posterior to anterior. It has been described by Kashiwagi, reported later on, and it has been described arthroscopically by Reden, and of course it's not so difficult. You go straight in front of you, you just remove the bone with a burr, and at once you just fall down in the anterior compartment and you enlarge it with a burr, and here is the coronoid process. Of course, on the bony aspect, you can also remove the radial head arthroscopically. In this case, it's quite easy because you can destroy whatever you want, especially on the bone side. So you put a burr on the lateral compartment, you put the burr against the radial head, and little by little, you can remove all the radial head. Here is it. The capitulum is up till you join the radial neck when it starts to be mobile, and you can make some space with a grasper or whatever you want, or with spatula between the ulna and the neck of the radial head. The third step of the arthrolysis is the capsulotomy, which is, in my experience, is made at last, because when you open the capsule, of course, you let the irrigation, you make an extravasation of the fluid. That's why you inflate all the joint, and you see the brachialis muscle, which is just in front of the anterior capsule. And in my experience, and the experience of the French Arthroscopic Society, the only procedure which was performed arthroscopically was the capsulotomy of the anterior aspect of the joint. The nerve is protected, the median nerve is protected by the muscle. It has been described once to be resected by a shaver, but it's a real big fault which has been described on arthroscopy, not in our society. It has been reported in the literature. And regarding what proposed John O'Driscoll, capsulectomy, that means a resection of all the capsule, in our experience, you will see it's not beneficial to a simple procedure. Of course, you have to pay attention in front of the radial head to the anterior osseous nerve that Dr. Pedersini just reported you previously. There is some specificity for the synovitis. It's much more easy to remove the synovium, but you have to be aware because the capsule is very thin in case of disease, and there is a lot of hernia, and especially in the posterior medial recess where there is a nerve, so you have to be really careful about that. And in case of synovitis, surprisingly, you can expect a lot of resolving of the symptoms, but not of the mobility. The postoperative course, in my experience, I inject some analgesic intra-articularly. I rarely perform a local regional analgesia because I'm really afraid to check the nerve, and I perform some CPM and medication, and without any spleen, but a permanent rehab. The result in the literature comparing open and arthroscopic surgery, arthrolysis, is quite similar concerning the post-trauma stiffness, the post-trauma or arthritic stiffness, or the arthritic Allen stiffness. We performed with the French Arthroscopy Society a study comparing two populations, open arthrolysis in special center, arthroscopic arthrolysis in specialized centers. Of course, the inclusion and exclusion criteria were very strict to find two groups comparable. They were quite comparable regarding the mobility, regarding the age, the sex, the activity of daily living. There was only one thing which differed in both cases. In the open surgery group, there were more post-trauma patients, and in the arthroscopic group, there was most microtrauma patients. Of course, arthroscopy is much more adapted to sportsmen with some degenerative arthritis due to overload. So the radiological assessment was made, as I told you, with an arthro-CT scan. In all cases, it was a criteria for the inclusion. Here are the operative procedure. Just to note that in the open procedure, some people have been operated by the lateral approach, some by the medial one, and some by the posterior one. In the expert's hand, when you classify the difficulty of the procedure from 0, very easy, to 4, very difficult, it was not significatively different, but with a mild difficulty for all the practitioner. The operative procedure, just to show you that the bone was more resected in the group open, the capsule was always resected fully in open surgery and not in arthroscopic group where only capsulotomy was performed. Here are the results. If you look at the preoperative status, in red the arthroscopic group, in yellow the open group, what you can see that just the stiffness was quite more important with the open group, and it will recover during operation much more than arthroscopic group. You see, you can expect at the end of the operation a better flexion and a better extension. But surprisingly, at the final term, the open group lost motion in flexion and lost motion in extension much more than the arthroscopic group. Of course, the procedure is less aggressive and probably there is less recurrence of the bleeding around the joint. The complication in both groups was quite similar in percentage, and the gain of motion, as I told you, the flexion at the end was better for the arthroscopic group than for the open group. And the final subjective result was an improving of the pain, an improving of the activity of daily living. The return to work was quite the same in both groups. It was not earlier in the arthroscopic group, and the patient opinion was quite satisfying. Even a slight gain, because you know we talk about 10 degrees, 15 degrees, is satisfying for the patient. Some special remark regarding these studies. The worker compensation are worse, of course, that's normal. I suppose it's everywhere the same for return to work regarding those who were not in worker compensation. And the resurgery, that means when you reoperate after mobilization under anesthesia or previous arthrolysis, is not significant in arthroscopic or open group. But the time to surgery is significantly a prognostic factor. When you have a stiffness which is less than 2 years, the results are much more better, and this result drop down after 2 years. At the conclusion of this study, that we say that the procedure with open surgery is more extensive, more aggressive, that's normal. Regarding the bone, the capsule, it's much more aggressive than the arthroscopic one, but the final result is in favor of the arthroscopic one. There is still some studies on the run for that. It's like the warm-up of the planet. It just evolved. So the advantage of arthroscopy, it's clear. There is less neurovascular risk, less instability risk. The post-op pain is really decreased with an easier rehab, and the peri and intra-articular bleeding is less. That's why there is probably less recurrence and less drop down of the mobility after. And if recurrence occur, of course, it's easier to reoperate after an arthroscopy procedure than after an open one. And as it was my last lecture, I say, salam.